for today's CME. And first, I would like to introduce our two distinguished speaker. So, first, Dr. MVSV Prasad sir. So he has experienced orthopedic surgeon with over 45 years, and as well as the secretary of Hemophilia Society Vijayawada Chapter, chairman at India Red Cross Society, West Godavari District Branch, as well as the secretary at Managing Committee, Sir CRR Educational Institution Eluru. So, welcome to you, sir. As well as I would like to introduce our today's second speaker, Dr. I.S. Chaitanya Kumar, sir. And he is an additional professor at transfusion medicine and hemotherapy at Blood Center, AIMS Mangalagiri, Gantur, Andhra Pradesh. So, welcome you, sir, and to the audience as well for giving us the time for the CME. So I would just like to give a brief about today's CME. So first, we'll have a session on rebalancing hemostasis in the role of anti-TFPI by Dr. MBSV Prasad sir, who will take us through the introduction of the TFPI, and followed by our second session is there on a new era in the hemophilia, where the role of concizumab will be discussed by Dr. I.S. Chaitanya Kumar sir. He will let us go through the trial data and everything about the concizumab, followed by the question answer. So to the audience, if you have any questions regarding this, you can just put your question in the chat box, or you can unmute yourself and ask after the session. So I would like to invite and hand over to Dr. MVSV Prasad sir to start over his first sessions. Please.
Good evening, my dear friends. Today we are discussing about the role of rebalancing agents in hemostasis and the role of anti-tissue factor pathway inhibitors. This is mainly based on extrinsic pathway of the coagulation. First of all, you must have a knowledge of the status of hemophilia in India and world. And as per the 2023 statistics, total hemophilia population may be around 4,65,327 as per the world population. And out of them, both hemophilia A and B, we could locate, and others, 2,73,043, and another 83,451 are other clotting factor deficiencies in the world. Whereas in India, maybe there should be around more than 1,20,000 or 1,30,000 in total patients of bleeding disorders, including hemophilia A and B. Out of them, through the Hemophilia Federation of India, we could recognize 22,133 hemophilia A patients and 3,687 hemophilia, and other unknown types are around 532. Total, it comes to around 26,352. We could not even cross 25%. Only 8 to 10% of world hemophilia patients are in India. We have a large population of hemophilia patients in India. This is an important thing. There is still a lot we have to progress. So current scenario of prophylaxis in India, and it is in India 9% for the last 3 years, 2018, 19 and 20. Whereas Western Europe, other countries, Brazil, originally it is 2092%, but a sharp drop is there in 2019 and 20. And whereas in UK, from 87 to 92%, and Switzerland is another country where they give a prophylaxis for 100% support. So there are so many unmet needs have led to the continuous innovation in hemophilia care. There are many challenges in hemophilia care. Prophylaxis, this is very important. And olden days, cryoprecipitate or plasma-derived clotting factor concentrates are used for prophylaxis. They have their own complications and problems in those days. Later, because of the viral problems in 80s and 90s, there is a lot of hue and cry in the worldwide because of the HIV breakdown. And later heat treatment, monoclonal technology, and American Blood Bank Association solvent detergent methods. There are so many plasma derived products are heat antiviral treatment was done. Later, recombinant factors were introduced, and with these things, with the recombinant factors, there is no need for a human element in these things. So when the molecule is identified, it is produced in the biotanks. So there is no risk for the viral transmission. They are safe. In course of time, because of these things, half-life and other short-acting life of this factor 8 and 9, so many innovations have started. One is a gene therapy and a later non-factor treatments. So in the course of time, at the present status, longer dose intervals of extended half-life. Later, now we are came to a stage of non-factor treatments using the coagulation mechanism, the pathways and inhibitors which inhibit the coagulation mechanism. So these things have been taken into monoclonal antibodies, and the administration is very simple, subcutaneous dose with the non-factor treatments. So this is the progress for the period. In 80s, it is a disgusting. 90s is a factor plasma derived. By 1996 to 2000, recombinant technology and gene therapy. In 2020, after 2020, this is the non-factor subcutaneous administration with treatments. A lot of development has taken in hemophilia management with some problems. People living with hemophilia experience an unresolved disease and treatment burden. This is very important. This is a lifelong disease, and a cost of treatment and timely management is very cumbersome and a tricky issue, and the patient always lives in a stage of stress. To outcome this, we need a social psychological balancing. Outcomes for people with hemophilia have improved with a wider range of therapies and ability to individualize the therapy. However, there is an unresolved burden of the disease and its treatment, especially cost factors and the availability of the drugs in the developing countries. And in spite of all these therapies, the existing patients have giant health arthropathy, subclinical bleeds. Of all these things, another important is the emotional psychological burden on the patient as well as the parents and the family. And the physical functioning in Indian conditions, even for working for the last more than 35 years, 96% of our hemophilics, more than them, are physically some joint problem. So this causes impact on work and school life. And spontaneous breakthrough bleeds are another important stress and strain for these patients. And the burden of administration is also important because factors administration needs a IV line. And the another important factor in the management of hemophilia is unbearable pain that makes the people almost immobile or agony, which cannot be explained. Only the people who experience, they know the agony of the pain. People with severe hemophilia continue to self-report bleeds regardless of the therapy type. This is another important. When they are in trouble, they approach somebody or through the society, through the HTC, majority, if they are nearer to the HTC. But if it is away from the HTC, at least they contact by phone with the advent of the cell phones and so many things. So mean number of bleeds in the last 12 months of since switching to medications. Severe hemophilia A and prophylaxis. So it is 7, extended half-life 7, and non-factor therapies 2. So the number of bleeds have come down with the non-factor therapies. And severe hemophilia B and prophylaxis, both short half-life factor 9, it is 3, and extended half-life, it is 5. So a bit less amount of bleeds. People with hemophilia A annual bleed rate appear to be lower among those taking non-factor therapies than those taking factor replacement therapy. This is an important latest finding. This is still on study. Inhibitors in hemophilia. 30% of the patients hemophilia develop inhibitors, and up to 10% of those with hemophilia. But some world record says it is rare in hemophilia B, that too anaphylactic reactions are very common. Even it is less than around 1 to 2% of the hemophilia B patients have inhibitors, but that inhibitor patients is a severe life threatening with the anaphylactic reactions if you administer factors to them. This is a very important thing. So only factor 7 is the line of treatment for the hemophilia B inhibitor patients. And another important point is prevent exogenous clotting factor concentrates from achieving hemostasis, because factor 8 or 9, they doesn't act on them. So how much factor concentrates you give, they don't have any relief of the bleed or pain. So the best method previously is inhibitor tolerance immunization can be effective eradicating inhibitors in some patients, which requires very high doses of factor 8 concentrates in spite of bleeds or without bleed or with bleed, they should be in the high doses of factor 8. So in course of time, the body itself becomes resistant to the inhibitors, antibodies are produced, so they reduce the inhibitor level. Historically, bypassing agents were standard of care for treatment and prevention of the bleeds in patients with high titer inhibitors. This is with the advent of uh, APC and factor 7, to some extent we could do it. And latest thing is non-factor therapies like acting on the coagulation mechanism to prevent activating the coagulation factors in alternative methods. So this is the important thing. And another advantage is subcutaneous can be given. So the effectiveness and treatment and methods of treatment will be is, and they can be treated at home in spite of the inhibitors, the hemophilia A or B. So a greater burden of bleeding is reported hemophilia with inhibitors than without inhibitors. Compared with hemophilia patients without inhibitors, those with inhibitors experience like this: bleeds with inhibitors 3.7 to 8.3. This is the common thing, bleeds. And the giant bleeds also 2 times increase 2.2. Whereas one in a case of these inhibitors. And bleed-related hospitalizations are also very high in the inhibitor patients, because this is the importance of inhibitors. So we have to manage them with the latest trends. This has become almost a home therapy, management of inhibitors. People with hemophilia and inhibitors face a greater burden of joint disease compared with people with hemophilia without inhibitors. So this is about Clinical evaluation as per the European study of orthopedic status in hemophilia, it is 5.5 and in without inhibitors and 15.4 in with inhibitors. Pain evaluation 2.3 without inhibitors and 3.9 with inhibitors. Radiological evaluation, this is very high because it is a concealed problem. So radiological evaluation is 19.3 without inhibitors and 27.8 with inhibitors. So this is an important finding in the management of the hemophilia with inhibitors. So people with hemophilia and inhibitors face a greater burden of joint disease compared with the people with hemophilia without inhibitors. So reduced mobility requiring walking aid, nearly 29 without inhibitors, 50 with inhibitors. Reduced mobility requiring wheelchair, 4 without inhibitors, 24 with inhibitors. Required orthopedic procedures, 37 without inhibitors and 66 with inhibitors. So this is a problem. Inhibitors causes a lot of disabilities and other problems and agonizing life for patients with hemophilia. So current therapies for hemophilia may be associated with the high burden of preparation and administration impacting adherence. This is an important point, adherence. Treatment burden has been greatly elevated with subcutaneous therapy. However, activities of daily living are still impacted by hemophilia treatment regime. Improvements are needed. This is the way the latest non-factor therapies reduce need for venous access, dosing frequencies and delivery method meeting the personal needs of the patient, improved storage and portability. This is another important thing, almost a home therapy. A hemophilia treatment can result in barriers to adherence. One is complex regimens based on the dosage frequency with the factors, dosage amount, delivery method, storage, and portability. These are the things with the older methods of problems, treatment with the factors. So, despite therapeutic advances, unmet needs exist across all hemophilia subtypes. Burden of preparation and administration, bleeds and joint health, restriction in daily activities and quality of life. Hemophilia A with inhibitors, monitoring with non-factor therapies can be challenging. Concomitant use of bypassing agents in surgeries and breakthrough bleeds. Hemophilia B with inhibitors, no efficacious prophylaxis and few treatment options. ITA success rate is almost non-existent. And hemophilia A, monitoring non-factor therapies can be challenging. 50% of patients on non-factor therapies can still experience bleeds. And hemophilia B, no subcutaneous prophylaxis, limited data available on non-factor therapies, effectiveness in mild and moderate patients. So the current landscape of hemophilia is evolving to help address the individual needs of the patients. Extended half-life, factor 8 and 9 replacement, and factor and mimic substitutes for factor 8 function, rebalancing coagulation through factor 8 and factor 9 independent dynamic, disease correction. These are the methods. So extended half-life for factor 8 and 9. Factor 8 and 9 extended half-life factors are there. For mimic substrates for factor 8 includes factor 8 mimetic drugs and rebalancing coagulation through factor 8 and 9 independent dynamics, anti-siRNA, anti-tissue factor inhibitor agents, anti-APC protease inhibitors. These include for factor 8 and 9 Afansitol alpha company, factor 8 mimetic enzyme job, anti-siRNA is fitusiran, anti-tissue factor pathway is concept job and anti-APC protease is serpin C, and disease correction is simple gene editing and cell tags, adeno-associated virus gene therapy, live cell editing, cell therapy, non-viral GT, gene therapy. So the current emerging non-factor therapies includes first initiation of the clotting mechanism that includes tissue factor expressing. This is the alternate pathway, and once tissue factor activates factor 7A and factor 9 to factor 10A, and then it is the place where tissue factor pathway inhibitor comes in place. We could produce a monoclonal antibody to suppress the tissue factor pathway inhibitor, so the clotting process continues, and which itself activates factor 10A, factor 5A, and APC. Another thing is in this mechanism, APC anti complexes and serpin C amplification, they also inhibit the activate the factor 10 and factor 5A and factor 2 and factor 2A. Ultimately, propagation is there, serpin C or APC, factor 8 activation and factor 9 activation. Ultimately, here itself, factor 8 mimetics acts, activates the factor 7, factor 9, and factor 10. So these are the rebalancing agents. A balance between procoagulants and anticoagulants underpins the hemostasis. Normal hemostasis, we require factor 8, 9, 10, and 11. And for this activation, tissue factor pathway, AT, APC, HC2, PNI, and JPI are needed. When these agents balance, clotting, when there is a bleeding, clotting will also balanced hemostasis occurs. But in hemophilia A and B, 8 or 9 being absent, in spite of factor 10 and 11, where these tissue factor pathway are antithrombin, APC, SC2, or PNA are being absent, or one of them, though procoagulant factors are reduced, so the clotting mechanism is affected, and there is an unbalanced. There is no coagulation, so the balance is disturbed. So a balance between procoagulants and anticoagulants underpins the hemostasis. This is the towards rebalanced hemostasis. Towards rebalanced hemostasis, where tissue factor pathway and antithrombin are absent. So in this process, we have to achieve a coagulation. So in this process, anti-tissue factor pathway inhibitors have come into existence. So a novel target for anti-hemophilic therapy is tissue factor multivalent Konich type plasma proteinase inhibitor consists of 3 domains, K1, K2, and K3. So the tissue factor pathway has alpha and beta varieties. So it is expressed by alpha is expressed by megakaryotes and stored in platelets. Beta constitutes major pool of tissue factor pathway inhibitor located in endothelial cells and monocytes. TFI binds and inhibits factor 10A. So that calls K2 domain, they have to act. Anti-tissue factor pathway inhibitor agents have designed to target the factor 10A binding site K2 domain of the tissue factor pathway inhibitor. So in this way, the tissue factor pathway activates factor 10. So TFPA is a potential regulator of normal coagulation. So when tissue factor pathway inhibitor is there, is absent, it suppresses the factor 7A activation, 10A and tissue. So tissue factor is inhibitor acts. So when you thrombin generation is impaired in hemophilia. So the next problem is tissue factor pathway inhibitor comes into place. That is, it activates 10A and 5A, prothrombin 2 and anti-2 thrombin, and fibrinogen and fibrin in the presence of factor 13. So this way the coagulation is achieved. Inhibition of the tissue factor pathway restores thrombin generation of the tissue factor 7A and 10A despite factor 8 or 9 deficiency. Even though hemophilia A or B are there, through the extrinsic pathway mechanism, this tissue factor pathway inhibitor is inhibited, and so the coagulation mechanism starts. So the latest drug, the market has come, Concimzab. This is a drug where it can act both in fact 8 and 9 patients because it is bypassing agent for the extrinsic pathway mechanism it acts. So whether you have 8 or 9 deficiency, Concimzab is a drug that can be used for hemophilia A or B, even with inhibitors or without inhibitors, because it binds the tissue factor pathway K2 domain, which activates the things. Highly high affinity humanized monoclonal IgG1 antibody against tissue factor pathway inhibitor. Targets and inhibits tissue factor pathway inhibitor. Restores thrombin generation potential. Concimzab is approved in India for prophylaxis of hemophilia A with inhibitors, hemophilia B with inhibitors under 12 years of age. So, Concimzab clinical development program, Explorer 1, phase 1, phase 2, phase 3, phase 1B, phase 2 trials have completed. So, Japanese multiple dose trial has occurred. So, Explorer 4, phase 2, hemophilia with inhibitors, hemophilia B with studies have completed overall. So, the drug can be used, but this is a daily dose, subcutaneous dose. So despite available treatments, unmet needs remain for people with hemophilia. Summary. Anti-tissue factor pathway inhibitors, particularly Concimzab, is an emerging class of therapies that may address these unmet needs. With pen injector and device, Concimzab offers a convenient way of dosing patients.
Venkat, could you please invite Dr. Chaitanya Kumar sir to present? Sir, good evening, sir. Could you please start your presentation, sir? Can you hear me, sir?
I can you see my screen, sir?
Yes, it is visible, sir.
Okay, sir. At the outset, I would like to thank Dr. Prasad sir and team Novonardis for inviting me for this program. I'll go ahead with the presentation. This is about the new era in hemophilia, especially with the release of new molecule that is the concizumab. This presentation, and I have been supported by Novonardis for this presentation, but I don't have any potential conflict of interest pertaining to any drug or other interactions. So I'll go ahead and continue where my previous speaker has left. Despite therapeutic advances, actually unmet needs have existed across hemophilia, different subtypes actually. So it can be hemophilia A, B, hemophilia A with inhibitors and hemophilia B with inhibitors. So there have been multiple studies going on, like Prasad sir told. And if we see, like sir was telling, now there are many different new molecules which act on different phases of coagulation cascade. Coagulation cascade is something by which our blood clots. In hemophilia A or hemophilia B patients, uh, like factor 8, factor 9 will be deficient. So this causes increased chance of bleeding, and coagulation cascade may not reach up to complete clotting step. So the newer molecules that we have discussed till now is anti-tissue factor pathway inhibitor. It's a monoclonal antibody. It blocks especially at the K2 domain, that is Kunitz 2 domain of tissue factor pathway inhibitors. And this helps in getting factor 8A. So factor 8A not only activates 10 to 10A, it also activates 9 to 9A also. So once factor 7A is released, it can help in bypassing 8 deficiency also, and it can directly activate 10 to 10A also. So this is one plus point. And the monoclonal antibodies, here we can see the red lines indicate that they are inhibiting. So the monoclonal antibody, which we were discussing about concizumab, it blocks the K2 domain of tissue factor pathway inhibitor. Factor pathway inhibitor's main role is it inhibits factor 10A activation with the help of factor 5A, especially pertaining to the release of thrombin from prothrombin. So once tissue factor pathway inhibitor is blocked by this concizumab monoclonal antibody, 10A becomes more active. It cleaves prothrombin to thrombin with the help of factor 5 and other clotting factors. And this helps in, again, deliberate creation of final fibrinogen is activated to become fibrin. So the fibrin threads are again helpful in creating clot with the help of something called clot stabilization factor, that is factor 13, and this helps stop the bleeding. Now, if we see the propagation area, there are different molecules like the serpin PC. This is, I think, currently stopped. This inhibits activated protein C. Protein C is a anti-clotting factor. So once the anti-clotting factor is inhibited by serpin PC, clotting mechanism goes forward faster. So this activated protein C complex actually it inhibits factor 8A, factor 9A complex actually. Thereby it prevents bleeding usually. But once we use serpin PC, it stops this, and it is a procoagulant kind of thing. And the last but not the least is directly now we have something called uh, siRNAs. So what these do is they inhibit actually the thrombin burst. Actually, antithrombin is also released. The antithrombin synthesis is interfered by these siRNAs. So what happens is antithrombin formation will come down. So there will be sudden release of thrombin, that is called thrombin burst, which helps in formation of a clot, and it prevents bleeding. Uh, like Prasad sir was telling, in a normal person, there will be something called clotting factors and anticoagulation factors. So procoagulants and anticoagulants form a balance. What happens in hemophilia A and B patients is this balance is tipped off. Like for example, here we can see either 8 or 9 factors have gone down. So the number of anticoagulant factors are on the top side, while the clotting procoagulant factors are on the lower side. So this shifts the balance of clotting, leading on to bleeding tendencies. Now, what we can do is when we use different kinds of drugs like tissue factor pathway inhibitors, it can be siRNAs, it can be serpins. So especially in patients with factor 8 and factor 9, once we use those drugs, actually the anticoagulant pathway is also reduced. Means it also comes to a balance standstill. So neither the procoagulant factors are uh, on the winning side, nor the anticoagulant factors are on the winning side. So now if we see anti-hemophilia therapies, tissue factor pathway inhibitor is a multivalent Kunitz type plasma proteinase inhibitor. Kunitz is the discoverer actually of a protein kind of thing, which acts as a enzyme inhibitor. So this is called Kunitz type plasma protein inhibitor, protease inhibitor, and it usually TFPA has three such domains. So we can see this is K1 domain, K2 domain, and K3 domain. So K1 domain binds to factor 7A, 10A binds to K2 domain, and protein S binds to K3 domain. So the other part is usually associated with factor 5. This is the main tissue factor pathway inhibitor alpha. This is expressed on megakaryocytes and stored in platelets. So whenever there is bleed, whenever platelets get activated, it is immediately released locally. The other type, that is the tissue factor pathway inhibitor beta, it constitutes the major pool of TFPI. It is located on the endothelial cells and monocytes. So this has only two uh, Kunitz domains, that is K1 and K2, and it lacks the K3 domain. What happens when we use concizumab is it blocks the K2 domain here. So factor 10A will be not attaching to tissue factor pathway inhibitor, and it continues in the coagulation cascade. So this is the normal role, tissue factor pathway inhibitor. It binds to factor 7A, it binds to 10A. So whenever we use these concizumab drug, it blocks K2, so that tissue factor pathway inhibitor will not bind to 10A. And along with that, factor 7A is also is not going to bind to K1 because this is a big complex actually. So when this happens, the entire 7A will be able to activate not only 8 to 8A, 9 to 9A, bypassing factor 8. It can also activate more of 10 to 10A. So this is what happens. The tissue factor pathway inhibitor is not able to bind to this. So 10A, 7A, all these are in the bloodstream. It becomes a procoagulant environment and clotting formation happens. Finally, prothrombin is converted to thrombin, and thrombin, it in turn converts fibrinogen. This is the last protein which will be converted to fibrin. This fibrin forms a big mesh on wherever the bleeding happens. This also requires fibrin stabilizing factor, that is factor 13. Now, this is the concizumab. This is anti-tissue factor pathway monoclonal antibody. It binds to specifically K2 domain here. So this is a high affinity molecule. This is IgG4 type of antibody. So there are again among IgG molecules, there are four different kinds: IgG1, G2, G3, G4. G1 and G3 are associated with actually some complications, and G2 and G4 are better. G4 has the highest immune tolerance actually. So there is lesser chance of patients developing antibodies against this drug when a molecule is IgG4. It targets and inhibits tissue factor pathway inhibitor. It restores thrombin generation potential as explained previously. So this has been approved in India for prophylaxis of hemophilia A patients with inhibitors and hemophilia B patients with inhibitors. But the age of these patients should be equal to or more than 12 years. These are the different phases that we have seen concizumab go through. These are characterized into four different phases. If we see here, the phase one is actually the safety trials. We can see phase one, Explorer 1, phase 2, phase 1, Explorer 2 is there, Explorer 3 is there. So all these are single dose trials initially, later multi-dose trials have happened, showcasing the safety and tolerability of the drug and for pharmacokinetics and dynamics. Coming to phase 2 trials, Explorer 4 and 5 are there. So these two were used to find the dose and efficacy also along with safety. If we see here, there is Explorer 6 also. It is a non-interventional baseline data. And phase 3 is also there. This has been completed. Uh, the publications have also come up in the internet in 2024 and 23. So Explorer 7 and Explorer 8. Phase 3 trials actually more focus on efficacy. So I think around the world, somewhere around 140 patients were involved in this. And from India, for Explorer 7, 16 subjects are there. And for Explorer 8, 17 patients are enrolled. And the what I am about to show is from Explorer 7. Here we may be seeing that there is Explorer 9 missing. So Explorer 9 is a study which has studied the role of using concizumab as a weekly therapy. So, and Explorer 10 is a phase 3 trial for children. Currently, we are only using concizumab for kids and adults who are more than 12 years. The phase 3 trial of Explorer 10 may be helping us in whether providing data whether to use for children also. Now, this was published by Matsushita T in NEJM, New England Journal of Medicine in 2023. In their study, actually, there were two randomized groups. Means some patients will get prophylaxis, some will be on demand, some will not be getting any, like they will be getting a standard line of care. There were again two more non-randomized groups, that is group 3 and group 4. These are patients who transferred from other phase 2 Explorer studies. So we can see here some of the patients were randomized with 1:2 ratio. Uh, Concizumab dosing was there. Day one, they started the dose of 1 milligram per kg body weight, and from day two, the dosage of concizumab is 0.2 milligram per kg daily. This happened for certain time. There was a dose adjustment period of approximately less than 8 weeks. There was no dose adjustment beyond 8 weeks. Now, there is one more thing we can see here. The first group, they received on-demand therapy or prophylaxis after some time. While the groups 2, 3, and 4, they received concizumab prophylaxis before also and after also. And this continued for nearly 1 year, 56-week cutoff. The dosing regimen that they used is initial dosage of 1 milligram per kg loading dose. This is followed by 0.2 milligrams per kg per day dose. And at 4 weeks, what they have done is they have tried to assess the level of concizumab in these patients by conventional ELISA. So depending on how much levels it is there, they have used a potential dose adjustment in between 4 to 8 weeks. And this is continued till 24 weeks and later on up to 56 weeks. So there were few groups of patients, somewhere around 25%, who required escalation of dose to 0.25 milligrams per kg per day. There were also a small group of patients who required decreasing the dose. So A had the concizumab dose levels of less than 200 nanograms per ml, and patient B group had concizumab levels of more than 4,000 nanograms per ml. So these required reduction in dose, while the A group required escalation of dose. This helps us in maintaining the safety levels of drug in patients. So this is what I have told. 74% of individuals did not require a dose adjustment. 25% required escalation in dose, and only 1% required decrease in dose to 0.15 milligram per kg per day over the next 56 weeks. The endpoints that these patients have taken, these studies have taken is the primary endpoint is the number of treated spontaneous and traumatic bleeds. This was estimated as annualized bleed rate. The secondary endpoints that they have chosen for analysis is two such points are there. For example, one is the uh, 36 item short form health survey bodily pain score, and the other is physical functioning score. How much change is there before use of concizumab and after using concizumab? How are they able to fare well in their life? This is what they have taken. And other supportive secondary endpoints that they have taken include number of treated spontaneous bleeding episodes, number of treated spontaneous and traumatic joint bleeds, number of treated spontaneous and traumatic joint bleeds, target joint bleeds. Pertaining to safety, they have this is a mandate actually for any randomized control trials. Pertaining to safety, they had to choose the number of adverse events, including thromboembolic events, hypersensitivity type reactions, and injected site reactions. Now, if we see the annualized bleed rate in no prophylaxis group, it was showing somewhere around 11.8. There were 19 people who were participating in this group, and they had somewhere around 11, means it comes to 11 to 12 episodes of bleeding was there in these patients over a period of 1 year. The confidence intervals include, we can see here is the bleed number of bleeding episodes are somewhere between 7 to 20 times per year. Now, if we see the patients who are on concizumab prophylaxis, there were 33 patients who were on concizumab. The annualized bleed rate is only 1.7. Approximately, maybe we can assume it as two bleeding episodes were there in these patients. And the range in different patients is most patients may be having bleeding between 1 to 3 episodes over a period of 1 year. If we take the median, here we are talking about the mean annualized bleed rate. The median annualized bleed rate is 0 when patients are on concizumab. Means most of the patients, they did not have any bleeding episode. The maximum interquartile range here that has been shown here is 3, but median is 0. If we see no prophylaxis group, that is the 19 people who were not on concizumab, especially prophylaxis, but they were receiving on-demand therapy. So they had bleeding episodes between somewhere between 6 to 20 times over a year, and the median rate is 10. Now, if we see concizumab patients who had 0 bleeding episodes, nearly 63.6% of patients out of 33, they did not have a single episode of bleeding, while 12 patients, that is 36% out of 33, had bleeding episodes. If we see no prophylaxis arm, it is somewhere around 90% of patients had bleeding, and only 2 patients, that is out of 19, had no episode of bleeding. If we see the annualized bleed rates, concizumab prophylaxis group 2, that is 33 individuals were there in this group. Concizumab prophylaxis entire 2, 3, and 4, total 114 patients are there. Here we can see everything is 0, means no patient required bleeding episode with treatment, means there were no patients who had either treated spontaneous traumatic bleeding, treated spontaneous bleeding episode, treated joint bleeding episode, treated target joint bleeding episodes. And all, if we see all treated and untreated bleeding episodes, the no prophylaxis group had somewhere around 11 bleeding episodes, while concizumab group had only 2.6 to 2.2 bleeding episodes. This is both treated and untreated. Means even if they have bleeding, it did not require treatment. Uh, the 2.6% or 2.2 bleeds these patients who are on concizumab prophylaxis are taking. Now, concizumab prophylaxis resolved 92% of target joints at the 56-week cutoff in patients with inhibitor. So, if we see this, only patients who were on treatment for at least 12 months, that is 1 year, were included for target joint resolution analysis. And The percentage of target joint resolution we can see is 92%. Out of this, especially among adults, 90% of target joints have come down. In adolescents, that is more than 12 years, it is 96%. This is because probably adults may have had bleeding, more number of bleeding episodes, and that joints may be at a worse stage. That is why for them to revert back to normal joints, it may have required more time. It may require maybe after more than 1 year, it may come back. In this study, we can see patients with target joints result among adults is 30 out of 34. Among adolescents, it is 14 out of 15. Now, the overview of safety findings, we can see here, this included all the forearms. N is the safety analysis set out of 127 patients. Total adverse events they have reported is somewhere around 80. The 80 patients had adverse events. 356 events were recorded. So the event rate is somewhere around 3.2%. And if you see a 56-week event rate also, it comes to somewhere around 2.9%. Means out of 100 concizumab injections, maybe 3 injections may have some reaction. So out of these serious adverse events, they have checked somewhere around 14 patients had serious events, and these events are 18 in number. Fatal adverse events were also found in this study. Some like 2 patients had these fatal events. The events were somewhere around 4 at the 56-week period. The literature that shows this study, it shows that some of these patients had multiple risk factors, so which have led to thromboembolic episodes, like usage of maybe RF7A, other drugs also when they had severe bleeding. So this is the fatal adverse events that they have encountered during study. Adverse events leading to drug withdrawal, there were 4 patients who had this episode. Thromboembolic events prior to treatment pass, 1 patient had actually, and this was only 1 event. After the treatment pass, at around 56-week cutoff, thromboembolic events after treatment restart is 0, if you see. And the last but not the least is hypersensitivity type reactions, because it is a drug we use subcutaneously. 2 patients had hypersensitivity, that is only 1.6%. The event rate is so low, means uh, thousands of events of injection has been there, and maybe only 2 events had hypersensitivity reaction. Injection site reactions somewhere around 48 events had in 26 patients. So it comes to somewhere around 0.4%, means less than 1%. And some patients have developed anti-concizumab antibodies also, that is 33 here. And at 56 weeks, it is 35, but it did not affect the treatment in these patients also. These are non-neutralizing antibodies, one thing we have to remember. So it will not affect concizumab that we give also. Now, if we see further data from 56-week cutoff, the concizumab concentration remained stable all throughout the period. Here we can see the plots which shows concizumab levels. The starting blue period is in the first 1 day. So after injection, the levels have steadily reached to a plateau phase, which is by first day it is there, and it continued till somewhere around 88 weeks. That is somewhere around 2 years. And similarly, free tissue factor pathway inhibitor concentration within 1 day it has come down, and it stayed stable for the next 2 years. The thrombin peak, thrombin is the last but one factor, clotting factor, which helps in conversion of fibrinogen to fibrin. So the thrombin levels all throughout for these patients from day one, it maintained a plateau phase at a higher therapeutic threshold, thereby increasing the procoagulant activity and stopping bleeding in patients with inhibitors. So 72% here, this is again being reiterated. 72% required a same dose of 0.2 milligrams per kg body weight somewhere around 26% required escalation of the concizumab dosage, and one patient required reduction in the dosage. Now, if we see the patient experiences, which is also known as PRO, patient reported outcome, from this study, 8 PRO questionnaires were evaluated, which included different points. Actually, we can see the treatment burden. Hemotem is a questionnaire, endpoint questionnaire. Then there is treatment preference. So, which how the patient is requesting for help. It can be patient preference questionnaire. It is called. There is something else, that is device handling and preference. How the patient is liking the device, pen device or the loading device. Then there is something called HRQL. This is quality of life indicator. Similarly, they are also tracking the physical activity using actigraph tracker. Patient perspectives on the device. Semi-structured face-to-face interviews were also taken from the patients, all the patients. So if we see here, this picture shows the quality of life using short form 36-point questionnaire. We can see this group is the prophylaxis, non-prophylaxis group, and the second group, that is called the prophylaxis group. If we see here the no prophylaxis group, their quality of life did not improve. In fact, it has gone down. So bodily pain, whether it is statistically significant, we will not be able to assess. But if we see the concizumab group, these patients, we can see visibly the inner circle. It is there almost the same way, but the outer circle, all the uh, quality of life scores have improved. Everything has increased from the initial levels. The side chart, this forest plot we can see here, it shows that general health has improved by significant amount, vitality has improved by significant amount. Similarly, emotional role, mental health, and mental health component score have improved with use of concizumab. The other things we will not be able to provide a statistically significant difference because it has touched zero. But these points, we can see at least these things have improved significantly in patients who are on concizumab prophylaxis. Similarly, if we see how hemo A quality of life indicators are in these patients, especially patients who are on concizumab prophylaxis and those who are not on concizumab prophylaxis. Here, the lower scores, it means that it is better. So, in patients on concizumab, we can see the inner diagram has shrunk, means it has reduced on all aspects, especially pertaining to total score, physical health, feeling, treatment, view of self, sport, leisure, work, studies, dealing with hemophilia, partnership, sexuality, future perspectives. While patients who are not on concizumab prophylaxis, it has deteriorated. Everything has increased. If we see whether these are statistically significant in this forest plot, box plot, we can see total score has significantly improved in concizumab prophylaxis in these patients in the study. Similarly, their feeling of self, viewing self, in esteem, actually, it improved. Sports and leisure activity has increased. Treatment has increased. These have statistically significantly improved. While we can see partnership and sexuality, future, then work and studies, physical health also, the medians or means are just before zero. So these have also improved, but as these are crossing zero, it implies that this is not statistically significant. And similarly, dealing with hemophilia, we can see the median has shifted beyond zero. Means it is not favoring prophylaxis, but maybe this is a perspective. So we cannot exactly tell what they want. And similarly, it is crossing zero. So this is not statistically significant. Now, this is one more indicator, mean hemo TEM scores actually. This was tested at baseline and at week 24. So here we can see again lower scores indicate lesser treatment burden. So patients who are not on prophylaxis, the scores have increased actually. While patients who are on concizumab, the inner blue color hexagon is there. So it has shrunk significantly. It appears very small compared to the outer ring. So it means that the treatment burden has come down significantly. We will see the forest plots here. We can see the total score, injection difficulties, interference, emotional impact. All these 4 points have improved significantly, favoring concizumab prophylaxis. While treatment bother, physical impact, these have not significantly changed, but nevertheless, it has favored prophylaxis of concizumab. Similarly, if we see how the concizumab prophylaxis increased the time and intensity of activity in patients of concizumab prophylaxis with when compared with patients who are not on prophylaxis, moderate or vigorous activity relative to awake time was assessed. So in patients who are not on prophylaxis, it was in the minus actually in minus 2.5. While in patients who are on prophylaxis, it is 1.9. So the difference estimate, average difference estimate is somewhere around 4.41 uh, factor. And similarly, moderate activity relative to awake time was also checked, and vigorous activity also was checked. So the moderate or vigorous activity and moderate activity, there is a statistically significant difference between people who are on concizumab prophylaxis and those who are on no prophylaxis. So the p values are significant, less than 0.05. The vigorous activity is not much statistically difference, is not much statistically significantly different. This approximately translates to 30 minutes of additional walking or some moderate activity. Majority of patients actually preferred concizumab over previous treatment. So we can see here that is 93%. Only somewhere around 1% they preferred previous treatment, and 6% did not give any preference for different treatments. The reasons behind is these people have experienced fewer bleeds. They required less time in preparing or injecting. The injections are less painful. It is easier to remember to inject. They feel less emotionally distressed. They often know most of the time how to inject also. Okay. And 4% they have mentioned that it is due to some other reason that they like concizumab prophylaxis. Now, if we see how this drug is being administered, this is through a pen device. In India, I think two different formulations are there per ml. The current therapies of hemophilia may be associated with a high burden of preparation and administration. This impacts adherence. Adherence is the most important thing to prevent disabilities in patients. So, when the mechanism of action is simple, when the patient is easily able to administer himself this drug daily on a regular basis, it improves adherence and patient will have lesser complications. So this happens because in these patients, there are no complex regimens based on dosage frequency, the dosage amount, delivery method, everything is the same here, the storage and portability. So there is reduced need for venous access in these patients because it is a subcutaneous injection. The dosing frequencies, delivery methods, everything is the same and they can be learnt in a single sitting. And there is improved storage and portability. The drawbacks include
Please wait. He is having some network glitch. He is going to join again.
హలో. ఓకే, ఇప్పుడు కనిపిస్తుంది కదండి పిక్చర్. హలో.
Yeah, it is okay now.
ఓకే.
Drawbacks
We
started.
were discussing the different kinds of evolution of parenteral injection devices. Initially, we used to get vials actually with lyophilizates, means freeze dried powders were there. We used to inject normal saline sometimes distilled water, depending upon the drug that is present in the vials, and we used to reconstitute and give. Over time, this has become converted to vials with liquids. Later on, the next generation was pre-filled syringes. After that, pre-filled syringes with staked in needles. And now it is pre-filled pen devices with smart solutions also present. So as the newer generations of parenteral injection devices are coming, it is becoming more convenient and it is increasing the adherence among patients. So the role of devices we can see here. Long-term administration of vial treatment is associated with inconvenience. Sometimes it requires special personnel who can inject specifically IV, something like that. Similarly, discomfort and pain can affect patient adherence. Patient adherence can be improved with injection pen devices that increase the convenience of administration, something which simplifies administration. They just have to, if drug is there which they can administer subcutaneously directly instead of IV, it will definitely improve adherence. Similarly, pen devices are user friendly. They decrease pain associated with injection because the needle is very fine, 32 gauge needle, and that too only 4 length. So this is more intuitive and confident. Uh, it helps build up confidence in patients as they use. Now, pen device in hemophilia, actually, most of the patients, they prefer this if they have the option. Especially, this is from a study from US, UK. So this showed patients preferred these pre-filled pens over vials and syringes. Similarly, importance of device design is also there. A large utility study from UK, Canada, and US, it high value patients place on injection device itself because it is easier for them and it prevents many infections also. Improved utility and experience is also present when patients and caregivers actually use these pre-filled pens. And last but not the least, enhanced quality of life. They feel safe when they have easy to use pen devices, at least, which they can just administer directly instead of worrying whether they can get a vein uh, to inject IV drugs. Pen device in hemophilia, actually we can see person with hemophilia and preferred subcutaneous injection route via pre-filled pens over IV infusion and were willing to accept trade-offs for this switch. This is the willingness to accept additional risk diagram, which we can see adults with. Is my picture visible? Similarly, 2% caregivers actually they have seen risk of serious adverse events were lesser. Similarly, now if we see the concizumab pen injector, in this we can see this cap is for protecting the drug product from light. Here is the drug product. The needle is only 4 32 gauge needle. 32 gauge needle means it is very fine needle, and this is used with single use disposable needle. So every time we try to inject the drug daily, we have to change the needle also. The cartridges are 1.5 ml and 3 ml pre-filled medication cartridges. Every time we inject the drug, we will be hearing an audible click confirmation of dose delivery. So this the pen can deliver a maximum dose of half of the 1.5 ml cartridge, that is approximately 0.8 ml maximum dose can be administered. The display is also easily visible because of the large display here. There is requirement of very low dose force at the pen end, that is the push end, and dose selector is the last but one part. We can see here the average time to prepare and inject this drug. It is somewhere between 1 to 2 minutes. And the average time to learn to use this is somewhere around 7 to 8 minutes. By 7 to 8 minutes, a normal person can go through the literature and know how to ready the drug. And 98% of patients found that concizumab pen injector is easy or very easy to learn how to use. See device handling questionnaire results. 99% found the device quick or very quick to prepare and inject. 98% found the device easy or very easy to use. 98% successfully completed their first injection independently without anyone's help. 95% found it easier or much easier to use the device outside of their home. And 99% found it easy or very easy to store the pen injector because it can be stored at 30 degrees centigrade for 4 weeks. So laboratory assay. Concizumab had no or only minor effect on standard PT, APTT assays, factor 8, factor 19, factor 9 activity measurements, and similarly factor 8 and factor 9 Bethesda inhibitor assays, that is the uh, factor 8 inhibitor and factor 9 inhibitor assays. So this is not affecting any of these, and therefore is not expected to interfere with uh, patient decision making, clinical patient decision making. Therefore, these assays can be considered in clinical practice to monitor the patients with different tests while on concizumab prophylaxis. But one thing we have to remember here is when we are going to keep a patient on concizumab prophylaxis, we have to take precautions that adequate dose or adequate time period is there between different kinds of drugs, whichever they are already on treatment. For example, if a patient is on APCC, somewhere around 48 hours should have been completed before we start concizumab. Similarly, RF7, I think it is somewhere around 12 to 24 hours. Like that, different drugs have different time periods of gap before we can start them on concizumab. Guidance for managing mild, moderate, and breakthrough bleeds during Explorer 7 trial with concizumab is, in this study, if patient is having breakthrough bleeds even with concizumab, what they have done is, for mild to moderate bleeding, most of the times this is uncomplicated musculoskeletal, mucosal, or subcutaneous bleeding. So they treated based on the protocol guidance. If it is life-threatening, then these patients were treated based on the physician's discretion. The usual dose of treatment is, because these patients have already inhibitors, they started initially with RF7A, that is, they gave somewhere around 90 micrograms per kg body weight. If it is not coming down with this, then they gave a dose of APCC of 50 IU per kg body weight initially. They tried to not give more than 100 IU per kg over a period of 24 hours during the trial. So patient can contact center during these episodes in the trial. So this is to sum up, concizumab is a new treatment in the therapeutic armamentarium for hemophilia with inhibitors. This is anti-tissue factor pathway inhibitor, IgG4 antibody specifically. It binds to K2 domain. Then it is a subcutaneous administration device, pen device, which is easy to use. It is helping in normalizing thrombin generation in even hemophiliac patients also. As we have seen, the thrombin levels have improved once they are on concizumab. It has a considerably good efficacy profile. The safety profile is also good. It improved quality of life in patients who are on prophylaxis compared to patients who are not on prophylaxis. There is reduction in treatment burden, as we have seen in the last picture. So thank you. If you have any questions, I'll be happy to take.
Thank you very much, Doctor. It was a wonderful session and much detailed session by both the speakers, Dr. Prasad sir and Chaitanya sir. I request the participant to type their question in the chat box. And few questions were already asked, doctor. So let me read out one by one so that you can address them. So the first question is, doctor, how this current therapy will score over the non-factor currently available non-factor therapy?
This is also a newer drug, so it may be similar to currently available non-factor therapies. And when something like this is there, it will obviously uh, reduce the costs of non-factor therapy in patients, and maybe the patients will get better quality of life when they start using these.
Okay, and another question, sir, is there any mortalities were reported during the trial with concizumab?
Yes, I have shown that two patients had fatal reactions actually, and I have gone through the literature present in US FDA and in the manuscript of the publication. So in the manuscript and US FDA guidance note, what they have mentioned clearly is some of these patients had multiple risk factors already because these patients had inhibitors. So when there is a bleeding, especially when they are put on RF7A, then again APCCs, it itself can increase the chances of thromboembolic manifestations in these patients. So I think, but after adjustments, I think there were no fatalities in this study as I have shown during the presentation.
Thank you, sir. And sir, another question, since it is a non-factor therapy and it is an anti-TFPA, can we use this concizumab to treat 1 milligram factor and Glanzmann thrombocythemia?
Without trials, we cannot say anything how whether it will improve or not. So till some trials come up, actually it will not be able to. We cannot justify. We cannot say that it is statistically significantly different.
Thank you, sir. And another question, sir, already we are very familiar with emicizumab therapy. It is like once in 15 days. But this concizumab therapy is showing daily dose. And what is the scope of this molecule?
Like I said during my presentation, current dosage is daily once, but actually the Explorer 9 trial actually it is I think on way. It is comparing I think weekly once therapy. So maybe if it is good in that study, if some good data comes up in that study, maybe it may be permitted to use every weekly once also by DCGI, CDSCO, and maybe USFD also. But currently, what we have data, it is showing the daily dose therapy only.
Thank you, sir. And another question is that the pediatric trial are still going on or is already reported? The one
Pediatric
about
trials are still going on. It is yet to be published. That is Explore 10.
yes, sir. Thank you. And they want to know the cost of therapy versus emicizumab.
I practically don't know the cost of concizumab. I'm yet to use for my patients. Maybe if we get some drug through different schemes, maybe I can use till that. I don't know exactly. I cannot comment on the drug cost. Maybe Singareddy can help here.
Sir, definitely will update you sir, in the post.
The cost of drug, can you inform?
Yes. And sorry, and another interesting question is that the emicizumab with the APCC, there is a reporting of thrombotic event. And what about this therapy? Is there any limitation when breakthrough bleed happen with the concizumab?
With concizumab also, there are certain limitations, but like in our study, even they have used RF7A and APCC. And before we start concizumab also, the US FDA guidance note says that we have to maintain at least some gap. For RF7A, it is different. For APC, it is different. If patients are on factor 8, uh, without inhibitors also, they have to wait at least some 12 hours is there. So it is a tricky situation. Each patient has to be judged differently, and usually the treating clinician will be giving treatment based on what they are already on. So we have to be careful. But once the doctor gives a prescription to the patient, it is okay.
In vitro diagnosis.
Thank you, sir. And the final question is that can you elaborate the needle size used in emicizumab versus concizumab?
Emicizumab needles are actually pre-filled syringes. Here it is pen devices. So I think the thickness of needles are almost the same. Maybe the needle length may be slightly more in case of emicizumab, and it is 4 mm in concizumab. That is the only difference. One is a pre-filled syringe and the other is a pen device.
So that's the end of the questions being asked in this chat box. So if there is any questions, I'm requesting the participant to turn on the mic and ask, or type in the chat box so that we can get clarified in that.
We don't know what it is. మన వాళ్ళకి ఏమైనా చెప్పారు? To conclude. Venkat, please conclude the meeting.
So, thank you very much for Dr. Prasad sir and Chaitanya sir for giving an elaborate discussion about the concizumab, and I thank the participant for patient listening, and even though in between we had some glitches, but still the meeting went on very well. So thank you very much for all the people who have participated and the speakers also. Thank you, sir.
Thank you very much.
Thank you, sir. Thank you.
Thank you.
Thank you all.
Thank you, Venkat.
Thank you.